Hello, everyone. This is Dr. Carmen Puliafito, and I'm here with David Almeida of Erie Retina Research in Erie, Pennsylvania. Dr. Almeida, welcome to Retina Synthesis.
Hey, thanks so much for having me, Carmen. It's great to be on here, and following your updates regularly, it's a great way you have to distill upcoming and latest trends to our community.
So today we're going to talk about the intraocular telescope for macular dysfunction and as a low vision aid. Even though we're in the revolutionary era of retinal pharmacotherapy, not all of our patients end up with fantastic vision. So the intraocular telescope is a concept that's been out there for a while, but there's a new iteration of the device that shows particular promise. Can you tell us a little bit about the optics of the intraocular telescope and its current indications?
Yeah. The indications is an important one, Carmen, because this is going to be for patients that are still phakic and have essentially worse than 2200 vision in both eyes. So bilaterally legally blind patients, patients that traditionally have been, left without much therapeutic options for intervention. In terms of the so phakic is an important one too, because there are not too many 70 or 80-year-olds are still phakic. Nonetheless, that's going to be your kind of criteria. And then the telescope is where, compared to the first generation, it's now bridging more into a more cataract approach. There's an injector, it's a smaller wound for these patients.
What's the optical power of the telescope?
How it happens, you take the patient's best eye, and that eye is going to be their central vision eye. That gets the IMT telescope. It gives you a 2.7x magnification, which allows basically 54% of magnified central field to be put over the whole macula. So a larger area over the 20 degrees, allowing basically to magnify that central vision. The other eye remains left alone, and it becomes a peripheral vision eye. So there's no rivalry component to it.
So tell us a little bit about how this new version is different than the old one, which had very limited adaptation in the United States.
Yeah, and that's such a good point, Carmen, and an important one to really look at, because the first generation telescope, also known as the Gen 1, and the new one is called the SING, the small incision novel generation IMT. And the big one was going into an injector, which allowed the corneal incision size to be decreased from about 12 millimeters, huge wound, to still a large one at about 6.5 to 7.5 millimeters, but now only requiring about 3 or 4 suture closure versus about 10 to a dozen before. The procedure durations decreased from about an hour plus to about 30 minutes, and now post-operative time to actually recognition of vision and by the patient went from about 3 weeks to maybe a week or so. So a good improvements, and probably from a safety point of view that the phase 3 Concerto trial is really looking at is endothelial cell loss. We saw a high number in the Gen 1 device, about 23 to 25%, which is now down to an 8 to 10.4% based on the European studies. So those are kind of some of the key differentiators between Gen 1 and the SING IMT.
Can you tell us a little bit more about the surgical technique?
Yeah, it's going to be evolved two stages really. One's going to be your more traditional cataract surgery. How I've done it is basically I do the implant, and I have a sub investigator named Anthony Sala who does the cataract. So after the cataract's removed in your typical phaco way, then the IMT is loaded into a specialized injector. The wound is enlarged to about 7.5 millimeters, and then it can kind of be engaged into the capsular bag like you almost would do an IOL, but slower, a little bit more controlled, because you got to get these 3 larger haptics and ensure they center into the bag.
Why can't you use it in pseudophakic patients?
Likely the main thing is going to be two aspects. One, the vision's probably going to be different because now they're pseudophakic and they may have some improvement in vision that changes that criteria. And second is just you're not going to be able to put it into the bag. You won't be able to do a lens exchange with it. You'll likely rip the bag. Any fibrosis, it really needs all of the bag open with usually a light dispersive viscoelastic to really support the IMT and introduction into the eye.
What's the visual rehabilitation like?
This is a very, very different and typical clinical practice, because these patients are going to go kind of three different directions after, Carmen. One, after the surgery, they're still going to have the surgeon or the PI following them, but then they're also going to have low vision optometrist services that's going to be kind of working with their vision. And the most critical is a low vision occupational therapist that does both in-home and in-office visits to really kind of teach this patient how to use their new vision, how to use their new vision in their environment for safety.
Why is this better than external magnification?
That's yeah, because that's gonna be the natural comparison. Better vision, better useful vision, and usually much less complication rate and maintenance with versus the external one.
So how does it work with the one eye for periphery and one eye centrally? Is there confusion?
Yeah, so as long as that and the inclusion criteria is so important in vision, because as long as you get the better eye, and no eye has better than 2100 vision at the absolute upper limit, then you won't have any rivalry. You'll only conceivably run into an issue. We haven't seen that in the Concerto trial yet. Is if somebody got implanted where they still had good vision in the other eye, and now there would be some foveal or even macular rivalry.
You've done a small series of these. Can you tell us a clinical example of a patient that did very well? What the scenario was?
Yeah, they basically were about 2200 in both eyes. From one eye was actually end stage dry AMD, the other eye was end stage neovascular scar down. After about 2 weeks, the patient started to notice vision improvement, and then usually at about 3 weeks, they're starting to kind of get on with it, which is kind of nice, and they definitely increase in their independence and their ambulatory potential around their environment.
Can they read?
Reading, I've seen it in various forms, Carmen, where there's going to be some high magnification on top of what they're using to kind of gauge reading, but it does vary and patient to patient into how they're using their IMT.
What's the regulatory status of the device?
Yeah, so it's right now it's not approved. Concerto will be the phase 3 trial that the Samsara, which is the sponsor and the company who owns the IMT, is hoping for a regulatory approval.
So how do surgeons learn how to put the device in? What's the training like?
Yeah, there's both a virtual component and then a live multi-step training that's basically goes over the injector and injecting, and then the post-op care of the device.
Where do you do the live training?
Usually at your surgery center. So let's say before your first implant, you'll have like a session or two with the surgical team from Samsara.
So there's a vitreoretinal surgeon and a cataract surgeon involved?
There could be. I know in Europe, in the European study, it was mostly done by cataract surgeons. There's a little more crossover between, them, some complex anterior segment surgeons doing some, a little bit of retina, and some retina surgeons doing a lot of cataract, kind of the European Canadian type. Whereas here, I think you're going to see it more in the way we're doing it, where there's going to be a cataract surgeon component and then a retina surgeon component.
Well, David, thanks a lot for this update on an important option that we've been very optimistic about for a while, and we may be realizing some success.
No, awesome. Thanks for having me, Carmen. Appreciate it. And yeah, we're excited to see how the Concerto trial plays out.
Thank you.